may be secondary to another disease process. Associated disease may include some of the following: viral or respiratory infection, such as infectious mononucleosis, cytomegalovirus, or chronic active hepatitis, or immunoproliferative diseases, such as chronic lymphocytic leukemia and lymphomas. In addition, certain drugs can be absorbed onto red blood cells and are capable of stimulating antibody production. Example includes acetaminophen, penicillins, cephalosporins, rifampin, sulfonamides, and methyl-dopa. Often, however, the underlying cause of antibody production is unknown, so this is referred to as idiopathic autoimmune hemolytic anemia. Typically, the patient exhibits symptoms of anemia because of clearance of antibody-coated red blood cell by the liver and spleen. Hemolysis is primarily extravascular because IgG is not as efficient as IgM in activating complement. But intravascular hemolysis can also occur if complement does become activated. Patients with warm autoimmune hemolytic anemias are usually treated with corticosteroid or splenectomy in more serious cases. A new treatment with anti-CD20 or rituximab or alemtuzumab is now available for cases that are refractory to corticosteroid. These antibodies attach to B cells, causing downregulation of antibody production and other effector cell activity. Called autoagglutinins, a less frequent cause of immune hemolytic anemias typically are found in their 50s and 60s. They are thought to be triggered by antigens on microorganisms because antibodies have been known to occur following mycoplasma pneumonia and infectious mononucleosis. Cold agglutinins have also been seen in such disease as chronic lymphocytic leukemia, non-Hodgkin's lymphoma, myelodysplastic syndrome, or connective tissue diseases such as systemic lupus erythematosus. In children, such antibodies have been associated with virus and respiratory infection. These cold-reacting antibodies belongs to the IgM class, and most are specific for the Li blood groups on red cells. These antibodies usually don't cause clinical symptoms. Reactions are seen only if the individual is exposed to the cold and the temperature in the peripheral circulation falls below 30 degrees Celsius. Peripheral necrosis may result. Although complement activation begins in the cold, it can proceed at body temperature. If the entire complement sequence is activated, intravascular hemolysis may occur. If red blood cells become coated with C3b, these help macrophages to bind, and these cells are rapidly cleared in the liver, further decreasing the number of circulating red blood cells. A simple treatment is to keep the patient warm, especially the hands and feet, to prevent complement activation. Now, we're going to type 2 reaction involving tissue antigens. All the reactions that have been discussed so far deals with individual cells that are destroyed when a specific antigen-antibody combination takes place. Some type 2 reaction involves destruction of tissues because of combination with antibody. Organ-specific autoimmune diseases in which antibody is directed against a particular tissue are in this category. Goodpasture syndrome is an example of such a disease. The antibody produced during the course of this disease reacts with basement membrane protein. Usually, the glomeruli in the kidney and pulmonary alveolar membrane are affected. Antibody binds to glomerular and alveolar capillaries, triggering the complement cascade, which provokes inflammation. An evenly bound linear deposition of IgG in glomerular basement membranes, as detected by fluorescence labeled anti-IgG, is indicative of good posture syndrome. Treatment usually involves the use of corticosteroids or other drugs to suppress the immune response. Other examples of reaction to tissue antigen include some of the organ-specific autoimmune diseases, such as Hashimoto's disease, myasthenia gravis, and insulin-dependent diabetes mellitus. Immunologic manifestation and detection of this disease are present in Chapter 14. As discussed in Chapter 9, Combs' discovery of the antiglobulin test in 1945 made possible the detection of antibody or complement on red blood cells. Direct antiglobulin tests, or DAT, is performed to detect transfusion reaction, hemolysis disease of the newborn, and autoimmune hemolytic anemia. Refers to the exercise at the end of the chapter for details. Fully specific anti-human globulin is a mixture of antibody to IgG and complement components such as C3b and C3b, and it is used for initial testing. If test is positive, then it should be repeated using monospecific anti-IgG and anti-C3b and anti-C3d to determine which of this is present. If an autoimmune hemolytic anemia is caused by IgM antibodies, only the test for complement components would be positive. The indirect Combs test is used in the cross-matching of blood to prevent a transfusion of reaction. It is used either to determine the presence of a particular antibody in a patient or to a type patient red blood cells for specific blood group antigens. In vitro, binding of antibody to red cells rather than in vivo binding is detected by this method. This is a two-step process in which red blood cells and antibodies are allowed to combine at 37 degrees Celsius. And then the cells are carefully washed and to remove any unbound antibodies. Anti-human globulin is added to cause a visible reaction if antibody has been specifically bound. Any negative tests are confirmed by quality control cells, which are coated with antibody. Now let's go into discuss about the type 3 hypersensitivity. The type 3 hypersensitivity reaction are similar to type 2 reactions in that IgG or IgM is involved and destruction is complement mediated. However, in this case of type 3 diseases, the antigen is soluble. When soluble antigen combines with antibodies, complexes are formed that precipitates out of the serum. Normally, such complexes are cleared by phagocytic cells. But if the immune system is overwhelmed, this complex deposits in the tissue. They bind complement, causing damage to the particular tissue. The position of antigen-antibody complexes is influenced by the relative concentration of both components. If a large excess of antigen is present, sites on antibody molecules becomes filled before cross-links can be formed. In antibody excess, a lattice cannot be formed because of the relative scarcity of antigenic determinant site. The small complexes that results in either of the preceding case remain suspended or may pass directly into the urine. Precipitating complexes, on the other hand, occurs in mild antigen excess, and these are the one most likely to deposit in the tissue. Sites in which this typically occurs include the glomerular basement membrane, vascular endothelium, joint linings, and pulmonary alveolar membranes. Complement binds to these complexes in the tissue, causing the release of mediator that increase vasodilation and vasopermeability. Attracts macrophages and neutrophils and vasopermeability, and enhance binding of phagocytic cells by means of C3b deposited in the tissue. If the target cells are large and cannot be engulfed by phagocytosis to take place, granules and lysosome contents are released by a process known as exocytosis. This results in the damage to host tissue that is typified by type 3 reactions. Long-term changes include loss of tissues, elements that cannot regenerate and accumulate of scar tissue. Now we're going about the Athos reaction. The classic example of a localized type 3 reaction is the Athos reaction, demonstrated by Maurice Athos in 1903 using rabbit that had been immunized to produce an albudance of circulating antibodies. Athos showed that when this rabbit were challenged with the intradermal injection of the antigen, a localized inflammatory reaction resulted. This reaction characterized by erythema and edema, peaks within 3 to 8 hours and is followed by hemorrhagic necrotic lesion that may ulcerate. The inflammatory response is caused by antigen-antibody combination and subsequent formation of immune complexes that deposit in small dermal blood vessels. Complement is fixed, attracting neutrophil and cause aggregation of platelets. Neutrophils release toxic products such as oxygen-containing free radical and proteolytic enzyme. Activation of complement is essential for the Athos reaction because the C3A and C5A generates activate mast cells to release permeability factors. Consequently, the immune complex localizes along the endothelial cell basement membrane. The Athos reaction is rare in humans. Now we're going to talk about the serum sickness. Serum sickness is a generalized type 3 reaction that is seen in humans, although not as frequently as it used to be. Serum sickness results from passive immunization with animal serum, usually horse or bovine, used to treat such infections as diphtheria, tetanus, and gangrene. Vaccines and these things may also trigger this type of reaction. Generalized symptoms appears in 7 to 21 days after injection of the animal serum and include headache, fever, nausea, vomiting, joint pain, rashes, and lymphadenopathy. Recovery takes between 7 and 30 days. In this disease, the sensitizing and the shocking dose of antigen are one and the same because antibodies develop while antigen is still present. High levels of antibodies form immune complexes that deposits in the tissues. Usually, this is a benign and self-limiting disease, but previous exposure to animal serum can cause cardiovascular collapse on re-exposure. These symptoms have occurred with monoclonal antibody treatment using mouse antibodies to human cells. Now, however, monoclonal antibodies are genetically engineered human antibodies, and such reactions do not occur. Now we're going to talk about the autoimmune disease. Type 3 hypersensitivity reaction can be triggered by either autologous or heterologous antigens. Several of the autoimmune disease falls into the category systemic lupus erythematosus or SLE and rheumatoid arthritis are two examples. In SLE, antibodies are directed against constituents such as DNA and nucleohistones, which are found in most cells of the body. Immune complex deposition involves multiple organs, but the main damage occurs to the glomerular basement membrane in the kidneys. In rheumatoid arthritis, an antibody called rheumatoid factor is directed against IgG. Immune complex deposition occurs in the membrane of inflamed joints. Complement enhanced tissue destruction in both disease. Now we're going to discuss about the testing for type 3 hypersensitivity. In specific disease such as SLE and rheumatoid arthritis, The presence of antibodies can be detected by